Welcome again and good evening, everyone, and welcome to today's musculoskeletal prong session. Today's session is especially important because musculoskeletal cases in PACES are often not difficult because of lack of knowledge, but because candidates fail to organize their thoughts in a structured way under pressure. Our aim today is to simplify the process. In this session, we will focus on how to approach musculoskeletal symptoms systematically, how to identify the important clues from the history, and how to use prompts intelligently to narrow differentials with confidence. Remember, in PACES, confidence does not come from memorizing random facts. It comes from having a clear framework in your mind. So try to actively participate, think aloud, and practice the flow of questioning rather than simply listening passively. The more structured your thinking becomes, the easier the examination will feel. And always remember our principle: what mind does not know, eyes cannot see. So let us begin today's musculoskeletal prompt session. So today we are going to discuss some prompts. There are about 9 prompts from the musculoskeletal system that are coming in the PACES exam. And also you will face these prompts facing in real day-to-day life clinical practice. The prompts are hand pain, low back pain, knee pain, ankle pain, hip pain, shoulder pain, neck pain, diffuse body pain. Sometimes it can come as muscle cramp.
Meeting is being recorded.
And multiple joint pain. Some background noise is coming. So among these prompts, hand pain, low back pain, and knee pain, they are awarded as triple star prompts. Because if you look at the cases scenarios, they are most often comes. So let's start with our first prompt, that is hand pain. In the PACES exam, up to now in the last 5 years, hand pain has come with the following 5 diagnoses. It will be either joint pain or Raynaud's phenomenon, or it can be due to carpal tunnel syndrome or Takasu arteritis, or even it can be due to AV fistula. This AV fistula was a very much common case in the Delhi center. It has been used to come for the last 3 years, but recently in this date, Delhi center has not given this case. But this was a very common case in Delhi center. So, how to approach to a case of hand pain? Whenever in the PACES exam we are given with a prompt like a 35-year-old Mr. Alexander has come to you with hand pain. Please talk to him, examine him, and meet his concern. That is how the instruction will be given. So right after entering into the station, our first question will be, what do you mean by hand pain exactly? Is it joint pain? Is it color change on exposure to cold? That is the Raynaud's phenomenon. Is it tingling and numbness relieved by shaking and cold water? This indicates carpal tunnel syndrome. Is it pain at hand while doing some activity? This is the screening question for Takasu arteritis. And for arteriovenous fistula, for dialysis in patient of CKD, we have to ask, do you have any past medical condition like the chronic kidney disease? And do you undergo dialysis? And I will suggest to memorize these 5 questions for any case of hand pain. And up to now, in last 5 years, I have not seen any case of hand pain coming apart from these 5 diagnoses. We will later on learn how to approach for joint pain, how to approach for Raynaud's phenomenon. We will discuss this separately. But in the PACES exam, we will be given with the prompt of hand pain. And most of the time, if you don't ask the surrogate, what do you mean by hand pain exactly, he or she may not give you the exact information to guide you to the diagnosis. So better to memorize these 5 questions. Then, after asking these 5 questions, we have to analyze the pain symptom using the mnemonic ODPARA. All of you who have attended the first session are already acquainted with the mnemonic ODPARA. Here, ODPARA means onset, duration, initial episode, progression, aggravating factor, relieving factor, and associated features. All of these have been discussed in our first session. This is the ODPARA, and all of the registered candidate have already got the PDF. So onset, duration, initial episode, progression, aggravating factor, relieving factor, and associative symptom. How to ask them? It is already written in that PDF. Then we have to analyze that pain using another mnemonic, that is LICOR. And already it had been discussed in first session. What does LICOR means? L means location, I means intensity, Q means quality, and R means radiation. So for any kind of pain, we have to analyze it with ODPARA right after, we have to analyze with LICOR right after ODPARA. So may I know, is up to this, is it clear to all? Any question up to now? Yeah, Dr. Samia, what is the question?
Sorry, Bhaiya, no question. It was accidentally placed.
Okay. If you are clear, candidates are requested to show a thumbs up reaction so that I can proceed forward. Okay, I'm proceeding. So right after this, we'll learn individual approach of the diagnosis. First, joint pain. Suppose the patient have told you that I have joint pain. So that my hand pain means it is joint pain. So how to approach for joint pain? I'm discussing the joint pain approach for the PACES exam. Our first question will be, do you have any morning jamming? That is the morning stiffness. If the patient complains of any morning jamming, the next question will be for how long? Whether it is more than 30 minutes or less than 30 minutes. If it is more than 30 minutes, then it is called inflammatory joint pain. Otherwise not. If it is less than 30 minutes, then it is not an inflammatory joint pain. So after morning jamming, we have to ask any other joint pain. Then based on the presence and absence of morning stiffness, we have to divide our differential diagnosis. If the morning stiffness is present, then it can be either rheumatoid arthritis or psoriatic arthritis or systemic lupus erythematosus. All of the cases have come in the PACES exam. If there is no morning stiffness, then it is mechanical pain. For PACES exam, it will be either gout or osteoarthritis. This rheumatoid arthritis, psoriatic arthritis, basically these two diagnoses has come many times. The prompt is hand pain. Patient will complain the typical metacarpophalangeal joint and proximal interphalangeal joint pain. Sometimes, while doing physical examination, you can find some psoriatic rash. And SLE case has come 2 times, up to in the last 3 years, it has come 3 times. In Dhaka Center, it has come 2 times with the prompt of hand pain. The diagnosis later on came out to be SLE. So what will be the screening question? Joint pain, symmetrical joint pain itself is the screening question for rheumatoid arthritis. To rule out psoriatic arthritis, we just have to ask, do you have any skin rash? Even from the history, the patient denies of any skin rash, we have to particularly look for every possible areas that may have any hidden psoriatic rash. And in the separate physical examination video, it has been demonstrated in details what are the possible sites of psoriatic skin rash, starting from the nail pitting. And for SLE, the screening question will be, do you have any, apart from joint pain, we have to ask for any facial rash while going to the sun. So this is for inflammatory joint pain. Then if it is mechanical, it will be gout and osteoarthritis. How to approach to gout? I will discuss it in detail with wonderful mnemonic during the knee pain approach. In case of osteoarthritis, typically you will find some physical examination finding, like the Haberden's note and Busch's note. And the patient will be older, female, and the pain will be mechanical, that is increased after doing activity. It will not be inflammatory time. But in the PACES exam, for the hand pain, the inflammatory hand pains are the most important one, and they are coming every now and then. And this is all for a joint pain approach for the hand pain. Let me know from the doctors whether anyone has any kind of question or confusion from approach of hand pain due to joint pain. Only one thumbs up reaction. Everything clear? Dr. Yasin, are you clear, doctor?
Can this gout can gout come as a hand pain only?
Up to now, it has not come, but I will discuss it in detail during the knee pain approach. How to get your diagnosis for the gout. Right now, I'm just skipping it. It is not that much common. But this side is very much important. It will come, and it is coming, and it will come. Okay, I think everyone is clear. So let's
just one question.
Yes, sure, doctor.
Diabetic arthropathy, is that also going to present as hand pain?
No, doctor. Actually, in diabetes, whenever the arthropathy happens, it happens due to the neuropathy. So the patient will never feel any pain. It is also true for the Charcot joint. It will rather be leg swelling. I have not seen myself personally from any center cases coming as diabetic hand pain for the diabetic arthropathy. I have not seen, doctor.
Thank you.
Okay. Thank you for asking the question. The more question you will ask, the more clear it will become. So let's approach for the next. Our joint pain is done. Now come to the Raynaud's phenomenon. For the Raynaud's phenomenon, the screening question will be, is it color change on exposure to the cold? Right after asking this question and confirming the Raynaud's phenomenon by asking the screening question, we have to ask the 3 stages of Raynaud's phenomenon to confirm that it is truly a Raynaud's phenomenon. The 3 stages are pale, blue, and red. We just have to ask to the patient, have you noticed the color changes? Like first it turns to pale, then blue, then red. The patient will reply to you accordingly that yes, I notice first it becomes pale, then blue, and then red. It is due to hypoxia, then cyanosis, and then hyperemia. Then in the PACES exam, the Raynaud's phenomenon can come for 2 broad differential diagnoses. One can be connective tissue disease, another can be Buerger's disease. This connective tissue disease was the most common cases coming in the PACES exam. But in recent diet, like diet 1, at Pondicherry, Buerger's disease has come. So how to approach for them? We all know that connective tissue disease means it can be due to, we all know that connective tissue disease can be due to systemic sclerosis or SLE or mixed connective tissue disease. That they have all the they have components of many diseases like systemic sclerosis, SLE, dermatomyositis, polymyositis. One of the doctors have asked Buerger's disease. Yes, doctor. At Pondicherry in diet 1, Buerger's disease has been given. I will discuss in detail how to approach for Buerger's disease, how we can get your diagnosis easily, what will be the screening question. So let's begin with the connective tissue disease first. In our first session, the registered candidate have already got a PDF. At that PDF, you will get a set of questions covering all the connective tissue disease, like starting from the hand, any change in color of fingers after exposure to the cold. That was our presenting complaint and the screening symptom. The next question will be any joint pain, stiffness, any skin thickening, any difficulty in, any joint pain, stiffness, that is for any connective tissue disease. And skin thickening is the symptoms of systemic sclerosis. Then any difficulty in raising the arm or getting up from the chair. This is the question for dermatomyositis and polymyositis. Any hair fall. This is the hidden question for discoid lupus erythematosus. And this is actually hidden. I will discuss it, why it is hidden. Any grittiness of eyes and mouth. This is for Sjogren syndrome. Any eye redness, any pain at eyes. Any skin rash. Any rash at face after going to the sun. This is the question for SLE. Any mouth sore. This is also the question of SLE because in SLE, soreness is found in heart palate. Then any chest pain and cough. Chest pain for any symptom of pleuritis, also for pulmonary embolism. Because in SLE, serositis can happen, affecting the pleura and also the peritoneum. So that is why any chest pain and any tummy pain. And if it affects the lungs, like in case of rheumatoid arthritis, patient will have dry cough. Then any type of connective tissue disease has the most grave complication of affecting the kidney. That is why we have to particularly ask about the kidney symptoms, that is the urine output. We have to ask any change in urine output, that is the amount, color, frequency, and frothiness. Urinary symptoms are very much important to ask for any kind of connective tissue disease. So what has happened at Dhaka Center at Dietary, they gave a case of hand pain, and the diagnosis was SLE. And she was having a hidden discoid lupus erythematosus over her head. The candidates who attended this course, I talked them personally that please remove the hair to find that discoid lupus erythematosus for any case of connective tissue disease. And that findings was there, that is any hair fall. And patient may not aware of that DLE lesion. So our job is every time for any connective tissue disease patient, always remove the hair. Then whenever any change in the urine was asked, she was complaining frothiness and decrease in the amount of urine. So that means the SLE is affecting the kidney. So that is for connective tissue disease. And by asking these sets of questions, all the connective tissue disease can be ruled out. And we have to ask it by asking the screening question that do you have any joint pain, stiffness, and any skin thickening? If anything comes positive, then we have to proceed further. Otherwise, it is not needed. Is it clear to all? Any question from these sets of connective tissue disease questions?
Sir, I have one question that is it
Sure.
possible to have psoriatic arthritis without skin rash?
Yes, doctor. If you learn the pathophysiology, you will find that psoriatic arthritis may present even before appearance of skin rash. It is written there in up-to-date in all the guidelines.
Yes, sir. Thank you so much.
Okay, and there are particular things we have to examine during examination of psoriatic arthritis. Like you have to show the examiner that I am looking for nail pitting, and this is an acting. You have to palpate the nail and show the examiner that I am looking for nail pitting. If you just look at with your eyes, the examiner will not get it understand. You have to act like palpating the nail. All of this sequence of examinations are discussed in detail in our separate recording of physical examination, which is provided to the registered candidate in type 1 and type 2. And
I have to ask you a question.
Sure, doctor.
There's this thing that you mentioned about removing the hair. You mean removing the cap, right?
Actually, no. She may wear cap, but most of the time, the DLE lesion will be hidden inside the hair. Are you getting it, doctor?
Yeah, it will be in the corner of the ear or something.
No, it is just on the scalp.
It's
It
on the
was
scalp.
just on the
Okay.
on the scalp. If the patient complains that yes, I have hair fall, you may think that this can be diffuse hair fall, because in SLE diffuse hair fall is also present in any kind of systemic disease. It is called telogen effluvium. But unless you remove the hair, you will not find that delineation, and that will count a mark in positive physical finding.
To take the examiner's permission before doing that.
Yes, doctor. Every time you touch the patient's body, you have to take permission from the patient that I'm going to touch your hair. Is that okay with you? Whenever you are going to check the anemia, take permission from the patient. I'm going to touch your eyes. Is that okay with you? And this will prove your professional approach to the examiner.
Right. Thank
Okay. Most
Sir,
welcome, doctor.
can
Yes.
you repeat this DLE wala thing? I didn't understand.
Okay. If any case of connective tissue disease, patient complains of hair fall, you may think that patient is having generalized hair fall. Patient is you are seeing in your naked eyes. But I will suggest you, whenever any patient complains of hair fall, please remove the hairlines with your fingers after taking permission from the patient, because sometimes hidden discoid lupus erythematosus rash will be there, and that was there in Dietary Dhaka Center. The examiner was expecting the candidate will remove the will check in between the hairline whether there is any dilation or not. Got your point, doctor?
Yes, sir. Thank you.
Okay, most welcome. Another thing is that in physical examination video, you'll see that in any case of Raynaud's phenomenon, you have to offer bedside capillaroscopy during physical examination. And if you don't offer it, mark will be cut. That have happened at Kochi Center and multiple other centers. Because by doing the bedside capillaroscopy, you will differentiate Raynaud's phenomenon from Raynaud's disease. There's differences between Raynaud's phenomenon and Raynaud's disease. Raynaud's disease will be symmetrical and bilateral, but Raynaud's phenomenon will be asymmetrical. And you cannot make it diagnosed unless you check the blood vessels under this capillaroscope with oil. So you have to offer that. You don't have to do that examination. You just have to offer that. Okay. So that is for connective tissue disease. The next is Buerger disease. It came at Pondicherry at type 1. So what will be the, first let me tell you what is Buerger's disease. Actually, Buerger's disease is a vasculopathy. It happens in typically an individual of less than 45 years of age with evidence of tissue loss at hands and feet. So whenever you are entering into an exam and you are seeing patient is having amputation at both hands and feet, you can keep in mind that this can be a case of Buerger's disease. You have to make it confirm by asking the question, the screening question. And this Buerger's disease is affected for the, it happens for the smokers, and it affects the radial artery and the tibial artery most. It basically affects the artery, vein, and nerves. But due to the affection of the radial and tibial artery, patient can have amputation of hands and also the feet. So what should be the screening question? The screening question will be first, do you smoke? If she smokes or he smokes, how many sticks for how long? It happened at Pondicherry Center that a 40-year-old female was given, and she was having 4 to 5 fingers of amputation at hand and 3 fingers of amputation at the leg. In Buerger's disease, apart from smoking history, there's another particular history that the patient will give if you ask it. The history is superficial thrombophlebitis, and it migrates from one place to another. It happens that right from the starting of the amputation or ischemia, this superficial thrombophlebitis also happens. So how to ask for superficial thrombophlebitis? We have to ask, have you ever noticed a painful red tender line or lump under your skin, especially in your arms or legs? If the patient replies yes, then we have to confirm that this migrates from one place to the another. How to confirm this? Does it appear at one place, settle down, and then come back in another place? These two are the questions for superficial thrombophlebitis, and it is superficial migratory thrombophlebitis, and it is found in case of Buerger's disease. And Raynaud's phenomenon will be there for sure. Is it clear to all about the Buerger's disease? It is also called thromboangiitis obliterans.
Please repeat last question, doctor.
Which one, doctor?
Which mark by green?
Okay.
Last two
Actually,
question.
Okay. Let me start from the first. Our first question will be, do you smoke? How many sticks for how long? For Buerger's disease to have, it is not defined to have a definitive timeline of smoking. Then after smoking history, the next question is for superficial migratory thrombophlebitis, because it is also found in Buerger's disease aside from Raynaud's phenomenon. Raynaud's phenomenon and superficial migratory thrombophlebitis, these are very much common in case of Buerger's disease. So how to ask this superficial migratory thrombophlebitis? We have to ask, have you ever noticed a painful red tender line or lump under your skin, especially in your arms or legs? Because whenever there is inflammation of the vein at hands or feet, the patient will have noticed this painful red tender line or lump. Then, to confirm the migratory nature, we have to ask, does it appear at one place, settle down, and then come back in another place? So it confirms the migratory nature, and these two are the questions for superficial migratory thrombophlebitis, which is found in case of Buerger's disease. Is it clear,
Thank
doctor?
you. Yes,
Most
clear,
welcome,
very
doctor.
clear.
And never forget for the safety netting of any Raynaud's phenomenon. That is, always tell her to wear gloves whenever she is going outside in cold weather. And look at the drug history very carefully, whether she is taking any beta blocker. Because you may be given there, like the patient has some anxiety disorder and she is taking propanolol. You have to stop that. She may tell you that I use some vibrating tool because this is my hobby of doing gardening. You have to also safety net about, you have to tell her also that no, do not use the vibratory tool. And tell her to stop the OCP. Okay, regarding this oral contraceptive pill, there's one particular thing I have to tell about. Most of the candidates will mention that stop the oral contraceptive pill. But to prove you more professional, you have to tell not just stopping the OCP. You have to tell stop the oral contraceptive, stop the birth controlling pill, and I will refer you to the woman doctor.
Safe contraception.
Yes, to offer you with some safe alternative. This is just that you are not stopping the birth controlling pill only, you are offering some safer alternative because she needs some contraception. Clear to all doctors? Any question from this approach to Raynaud's phenomenon from connective tissue disease and Buerger's disease? Should I proceed forward, doctors? Dr. Yasmin, do you have any question?
No, thank you.
Okay. So let's approach to the next symptom, that is carpal tunnel syndrome. And it is the very much important cause of hand pain coming in the PACES exam. In fact, it is the most important one. So right after entering into the station, if the patient complains that the hand pain is like something like tingling and numbness that is relieved by shaking and cold water, then this is a case of carpal tunnel syndrome. In the PACES exam, if anytime any carpal tunnel syndrome is given, it will be due to any cause of weight gain. Up to now, in 100% of the cases, there is background history of weight gain. So basically, we have to approach for weight gain. So how to approach for weight gain? The approach for weight gain will also be discussed separately in our endocrinology pronunciation. Here the approach will be, is it intent? First, we have to ask, how much weight have you put up over how long? Then the second question will be, is it intentional or unintentional? Right after that, we have to ask, where have you put on the weight? Is it to a particular body side, like the face, back of the neck, then trunk and lower tummy? Or have you noticed your hands and feet are getting larger? Or you have gained weight generalized, that you have put on the weight all over the body. So if it is generalized, then this is the differential diagnoses are hypothyroidism, polycystic ovarian syndrome, and obesity due to overeating. But if the cause is localized, it is due to acromegaly or Cushing. I'm again repeating the screening question for localized weight gain for acromegaly and Cushing will be, in the acromegaly, we have to ask, have you noticed your hands and feet are getting larger day by day? And for Cushing, you have to ask, have you noticed you have put on the weight, particularly on your face, back of the neck, around your trunk and tummy? Clear to all? And all the time, the carpal tunnel syndrome in the PACES exam will be given as bilateral. So let me ask a question to the doctors. Can anyone tell me the most important differential diagnosis for any case of bilateral carpal tunnel syndrome? Any doctors, any volunteers?
Hypothyroidism.
Endocrine.
No, I'm not causing. No, doctor, I'm not asking the cause of carpal tunnel syndrome. Look at my
Most
question.
common.
You are finding some tingling and numbing sensation at both hands. So one of the cause can be carpal tunnel syndrome.
Cervical radiculopathy.
Exactly, doctor. Cervical myeloradiculopathy. Who is giving the answer? Let me appreciate you because you have given the right answer, and this has important implication. At Dhaka Center, thank you, most welcome, doctor. At Dhaka Center Day 3, this bilateral carpal tunnel syndrome just came. It was a dummy case. He complained of weight gain. And the most important differential diagnosis of bilateral carpal tunnel syndrome is is cervical myeloradiculopathy. And the only way from the physical examination to rule it out is to check the charts of both hands. And many candidates did not check the charts of both hands, and only for not checking the charts of both hands, marks were cut. Because cervical myeloradiculopathy is the most important differential diagnosis of bilateral carpal tunnel syndrome. Got my points, doctor, why I asked this question?
Yes. Doctor, meaning by jerk, deep tendon reflexes?
Yes, doctor,
or what?
deep tendon reflex.
Okay.
You have to check the biceps jerk, triceps jerks, supinator, and also the Hoffman.
Yes.
Yeah, brachioradialis and Hoffman. Because in cervical myeloradiculopathy, you can find some exaggerated jerk. Some jerks may be absent. It will depend on the level of the lesion. But it will be just acting. The examiner will notice whether you are checking the charts or not. And I have seen personally the feedback where only for not checking the chart, marks were cut. So never make this mistake for any case of bilateral carpal tunnel, which will be bilateral for all the cases in the PACES exam. For any carpal tunnel syndrome, never forget to examine the chart of both upper limb. And in the PACES exam, the carpal tunnel syndrome will, up to now, in 100% cases, it was due to weight gain. And there are 3 complications for weight gain in general. From now on, I will request every doctors to make it memorize in the mind. One is carpal tunnel syndrome, another one is obstructive sleep apnea,
metabolic
and another one is
syndrome.
osteoarthritis. These three, doctor, for the PACES exam, these three are important. One is carpal tunnel syndrome, one is obstructive sleep apnea, one is osteoarthritis. And you have to rule them out both from the history, from the physical examination, and from the investigation for every case of weight gain. Because weight gain is a very much popular prompt of PACES exam. You can be given a case of hand pain with background of weight gain, or you may be given a case of headache on background of weight gain. The diagnosis was obstructive sleep apnea. But besides, you have to rule out the carpal tunnel syndrome and osteoarthritis. If you don't do that, mark will be cut. Because if you notice, if you remember from our first session, our CCCA formula, that is confirm the diagnosis, find out the cause, find out the complication, and rule out the association. Yes, Dr. Samia, also back pain. Back pain is due to osteoarthritis in this case. Arthritis can affect the back and also the knee. So don't forget to rule out these three grave complications of any weight gain. How to rule them out? For carpal tunnel syndrome, we have already tell you the screening question, that is tingling and numbness at hands and feet that will be shaking and cold water. For obstructive sleep apnea, we have to ask any nighttime snoring. If the patient complains that yes, I have nighttime snoring, then we have to ask 4 other questions.
Daytime
Sorry,
sleep.
3 other questions.
Early morning headache.
Sorry, doctor?
Yes. Early morning headache.
Yes, doctor. We have to ask, do you feel fresh after getting up from the bed in the morning? And do you have any headache in the morning? Then the patient will feel dizzy due to sleepiness the whole day. So we have to ask, do you feel dizzy the whole day? Any problem is in intimate relationship, that is erectile dysfunction. And the screening question is snoring. So these are the confirmatory questions for obstructive sleep apnea. And at any time you get obstructive sleep apnea, can any doctor mention what is the important next safety netting from the PDF, Sajid?
Driving.
Yes, doctor, driving. That is the reason. Suppose you have been given a case of carpal tunnel syndrome, that is handshaking, real by shake, the tingling and numbness, real by shaking. But unless you ask the symptoms of obstructive sleep apnea, you will not get it found, and you have to stop the driving for obstructive sleep apnea. And stopping the driving of obstructive sleep apnea will carry out your mark in clinical communication skill. Unless you mention to stop the driving, you will lose your mark in clinical communication skill. That is why for all the weight gain from now onwards, remember these 3 complications. That is carpal tunnel syndrome, obstructive sleep apnea, and osteoarthritis of the back, and also for the knee joint. We have to examine this also. Like for carpal tunnel syndrome, we have to examine the hand. The examination sequences are discussed in detail in the physical examination video that we provide separately. For obstructive sleep apnea, we have to offer to measure the neck circumference. And if in the history the patient complains of obstructive sleep apnea, we also have to examine that for the loud P2, that is evidence of pulmonary hypertension. To rule out the osteoarthritis, in the physical examination, we have to palpate the knee for crepitation of the knee joints. And that is all for carpal tunnel syndrome. It may look simple.
Okay, I have a question.
Yes.
It is that cervical myeloradiculopathy, can it not
Yes.
come as unilateral?
It can come as unilateral. Yes, doctor. But cervical myeloradiculopathy is not a PACES case for long clinical consultation. It is only just in bilateral carpal tunnel syndrome whether we are ruling out cervical myeloradiculopathy. Did you get your answer, doctor?
Yes.
Please let me know if you face still any confusion. Yes, doctor. Dr. Abu Hania has asked, long-standing rheumatoid arthritis also causes neuropathy. Yes, doctor. Long-standing rheumatoid arthritis also causes neuropathy. It can cause peripheral neuropathy. It is true for your practical case, but not for PACES case. I'm telling. In this course, I just make focus on the PACES cases only. In real life, you will see a lot of cases. Like rheumatoid arthritis can also cause carpal tunnel syndrome. But up to now, I have not seen any cases of carpal tunnel syndrome given on the background of rheumatoid arthritis. That is why, to make it simpler, I just tell the doctors that just remember the weight gain approach for carpal tunnel syndrome, and you will get your diagnosis.
Tingling and numbness of the hands. Can we include Raynaud's as a differential diagnosis bilateral?
Sorry, doctor?
Can we include Raynaud's as a diagnosis?
Yeah, it has been
bilateral
discussed. It has been discussed already, doctor. That
Also,
Raynaud's,
hypocalcemia, can we add bilateral
Yeah.
tingling?
Up to now, in last 5 years, I have not seen any hypocalcemia cases coming in the PACES exam with hand pain. For Raynaud's phenomenon, it will be color change on exposure to the cold. Patient will also feel tingling and numbness. That is why after entering into the station, we have to ask these questions at a go. Like, is it joint pain? Is it color change on exposure to the cold? Or is it tingling, numbness relieved by shaking? Is it pain at hand while doing some activity? Or do you have any past medical condition that I should be aware of? Because in Raynaud's phenomenon, patient can also feel tingling and numbness. So unless you ask this question, you cannot be sure enough whether it is Raynaud's phenomenon or carpal tunnel syndrome. Did you get your point, doctor?
Thank you.
Okay, most welcome, doctor. So this is for carpal tunnel syndrome. Okay, let me ask you a question. Let's see who can answer this question. This is real PACES cases. To make the session more interactive, let me ask you a question and let me see who can give the right answer. At one time, a case came where a 35-year-old male actually, this case was given for a weight gain, not for hand pain. I'm just want to know how you can get the diagnosis. A 35-year-old male has come with weight gain. We will also discuss the approach to weight gain in our endocrine session. He was complaining that he is gaining weight day by day all over the body. It is happening for the last 3 months. And it is partly intentional, like he likes to eat a lot. He works at office, he has a lot of stress there. Sorry, in the past medical history, let me tell you one by one. He's gaining weight for the last 3 months. It is all over the body. In the past medical history, he has been diagnosed with bronchial asthma. In the drug history, he's taking steroid for the last 3 months. And he works at a corporate office. He has a lot of job stress. And to combat his stress, he eats a lot of biscuits. So based on this, what do you think? What are the differential diagnoses for this weight gain? In the family history, her mother is a diagnosed case of hypothyroidism. So what do you think, doctor? What should be the differential diagnosis for this weight gain?
Cushing, iatrogenic Cushing, pseudo Cushing also for stress.
Yes, doctor. Iatrogenic Cushing is one, and another one is pseudo Cushing. Can you mention why pseudo Cushing?
I would put the hypothyroid first.
Stress.
Yes, due to stress. Yes, and also we have to rule out hypothyroid. But the patient was not complaining of any weather preference. But we have to rule out hypothyroidism because there is family history.
Family history.
Yes. And have you looked? The history was, the weight gain was not to a particular body side. In case of Cushing, in case of Cushing, it is typically should be happen in the center part of the body, but it does not follow the same in all the cases of PACES exam. Most of the time, they will give you the information so that you can think some differential diagnosis. This was actually a dummy case. They just put some obese guy there with past medical history of asthma, taking steroid for a long period of time, family history of hypothyroidism, but no weather preference, and there is job stress, and he takes biscuit a lot. Okay, one important diagnosis has been missed. What is that?
Insulinoma,
No,
maybe? Insulinoma?
No, doctor.
No.
Or a contraceptive?
Okay.
No, he's taking biscuits. So why not
Diabetes.
simple obesity?
Simple obesity.
Yeah, simple obesity. It is that much simple. So that was the differential diagnosis. And for all case of weight gain, never forget the three differential diagnoses, the three complications. They are carpal tunnel syndrome, osteoarthritis, and obstructive sleep apnea. And that's all for carpal tunnel syndrome. Any confusion from any doctors from this most important cause of hand pain? Okay, I think everyone is clear. So the next approach, the next cause of hand pain is tachycarditis. It is very much simple. The screening question is it hand pain at hand while doing some activity? It will be typically a middle-aged female or young female. And whenever you are asking the hand pain while doing the hand activity, it will be tachycarditis. In this case, we have to be cautious of one thing. That is, we have to check all the pulse, and all the bruit. Bruit means carotid bruit and also the subclavian bruit. Also, we have to check for renal bruit. In the carotid region, we can auscultate the carotid bruit. But for auscultation of the subclavian bruit, we have to auscultate below and above the clavicle on both sides. And also, we have to check for renal bruit. At the same time, we have to check pulse of both hands. The way of checking the pulse is that approaching from distally to the proximally. So first we have to check the radial pulse, then brachial pulse, if it is present, then carotid pulse. In this way, we have to approach from distal to the proximal. And one thing is that we can skip examination of the lower limb, that is pulses of the lower limb. Can any doctor give the answer why skipping examination of the pulses of the lower limb can be done? Why it can be omitted? Or in case of tachycarditis, this exact question was asked to a candidate at Kolkata Center by a British doctor. Any volunteer? Why in tachycarditis we can skip examination of pulses of the lower limb?
Because
Yes.
It's an aortic arch disease.
Yes, doctor, aortic arch disease. It was exactly the answer given by that candidate. He passed at first attempt from Kolkata. Sorry, excuse me. So that is the simple thing, and we have to examine all the pulse and all the bruit. The diagnosis is tachycarditis. The next cause is arteriovenous fistula. This was a very much popular case for Delhi Center for 3 years at a long. But from this diet, they are not keeping this case. So what are the causes of AV fistula and what are the screening question? The screening question is directly we have to go for the past medical history, whether he is having any kidney problem and does he undergo any dialysis or not. Then we have to know what are the causes of pain in arteriovenous fistula. These are the 4 causes. The causes are, it can be due to aneurysm of that AV fistula. It can be due to ischemic Still syndrome. Ischemic Still syndrome means the blood supply is hampered to the distal portion of the AV fistula. So the distal portion of the AV fistula, that is the hands, the fingers, become ischemic, and the patient feels some pain. because the blood gets diverted through this fistula. It can be due to any local infection. This is called infected AV fistula. Or it can be due to any thrombosis or stenosis of AV fistula. In that case, you will not find any bruit or any palpable thrill.
Sorry, can you repeat ischemic stroke syndrome? I didn't understand.
Okay, what happens in AV fistula? Suppose this is my hand. My hand is not okay. Suppose this is my hand. This is my finger. So what happens in AV fistula? A bypass is created here. So in ischemic stroke syndrome, blood gets diverted through these bypasses instead of reaching to the distal portion. So eventually, the distal portion gets less blood supply when needed. So it feels pain. Did you get your answer, doctor?
Yes.
Okay. Any other question from this?
Doctor, means the idea of causing of pain in the AV fistula is decreasing the blood supply to the distal part.
Yes. We have to look at what is the site of the pain. If it is over the site of the AV fistula, mostly it is localized cause, like aneurysm formation, or local infection, or thrombosis or stenosis. But if the patient complains of pain at the distal portion of the hand, then it is due to ischemic stroke syndrome. Did you get my point, doctor?
Yes, and only in the distal part.
Could you repeat that once again?
Which one, doctor?
The last point that you made, could you just speak it again?
Okay. In case of AV fistula pain, we have to localize what is the site of pain. For any case of pain, localization is very much important. Suppose this is the AV fistula. If the patient complains of pain over this site, then we have to make it understand that the pathology lies somewhere inside here. What can be the pathology? It can be any aneurysm formation, that is ballooning or dilatation of the AV fistula wall. Or it can be due to any localized infection over the AV fistula site. Or it can be due to blockage of AV fistula. We call it stenosis or thrombosis. But if the patient complains that he feels pain at fingers, then we have to think that the fistula is stealing the blood from reaching to the distal portion of the hand. In that case, the cause is ischemic stroke syndrome. Did you get it, doctor?
Yeah,
Do you
thank
need to repeat it again?
I got it. Thank you.
Okay, you are most welcome, doctor. So these are the causes of hand pain that has come in the PACES exam up to now in the last 5-year period. And for any kind of pain, like hand pain, in the physical examination, never ever forget to check the functional capacities of the hand. Because if you remember the CCCA formula, we have to rule it out from the history, from the physical examination, and also from the investigation. So from the physical examination, to rule out the complication of hand pain, we have to check the functional capacity. Because in the UK, in perspective of UK, if the patient is not able to do the activity, you have to offer some professional help in terms of social worker, not social worker, it will be occupational health worker. That is why you have to show in front of the examiner that you are checking the functional capacities. And the way to check the functional capacities is you can do one or two, like, can you make a fist and open your fist for me? Or you can just tell the candidate that, can you button or unbutton your shirt for me? Anyone will do. Got my point? Any type of pain, like if the patient is complaining of hand pain, you have to check the functional capacities of hand. If the patient is complaining of low back pain, you have to check the gait. You have to check the gait also for knee pain, ankle pain. So for all the types of pain, please don't forget to check the complication from the physical examination, because if the patient is having some complication, we have to offer help, that is professional help. So let me know from the doctors whether it is clear to all that is hand pain approach. Can I expect any question from any respected doctors? No question from anyone? All things are clear? Okay. Only
Suppose
three.
there's a hand pain case, we have to do the general examination according to the disease which you are expecting, no?
Yes, triple CA. Remember the triple CA. Confirm the diagnosis, find out the cause, rule out the complication, and find out the association.
So, how in case of Barger disease and Raynaud's phenomenon, so how can you differentiate between Barger disease and peripheral vascular disease?
From the history,
Okay.
okay, let me show. In case of Barger disease, the patient will be younger, less than 45 years age, and there will be long-term smoking history. But in case of peripheral vascular disease, the patient will be older. There will be past medical history of some cardiovascular disease like the diabetes, dyslipidemia, hypertension, also smoking for quite a long period of time. For PACES exam, just keep in mind in short that it will be older patient. But if you have been given a young patient who is having this amputation-like findings, it is surely due to any Raynaud's phenomenon. It can be any connective tissue disease or it can be due to Barger's disease. But peripheral vascular disease, patient will be older. Did you get your answer, doctor?
Yes, thank you.
You are most welcome and thanks for asking the question. So if there is no question from the hand pain, can I proceed to the next triple star problem? Yes, Dr. Raja, triple CA also for the examination. And what are the examination we have to do for each particular case, that is discussed separately in the physical examination video, which is provided to the registered candidate. Actually, what we do after discussing this POM session and after the practice session has been done from the previous POM session, certain cases are provided to the registered candidate. And all the physical examination sequence that have to be done is also provided in the form of a recording. So how to incorporate the triple CA is discussed separately in another recording.
Hello, sir.
Yes, doctor.
Would you provide a recording of this session because I joined late?
This is going to be the last pre-session of this batch. So it will be recorded and will be provided at the YouTube channel.
Okay, thank you very much.
Okay, you're most welcome. So let's proceed to our next triple star prompt, that is low back. Okay, there are some examination sequences showing here. It is the acromegaly clinical features or acromegaly examination sequence. Actually, these are the parts that are given to the candidate in registered candidate in the physical examination section. So let's discuss the low back pain. It is also a triple star prompt and very much common. So how to approach to a case of low back pain? First, we have to ask for morning stiffness. The non-jargon term of morning stiffness is morning jamming. We have to ask, do you have any morning jamming? If it is present, then whether it is more than 30 minutes or less than 30 minutes. Then we have to analyze the symptom using the mnemonic OT-para and LICOR. And inside the LICOR, location for any type of pain is very much important. Because what happened at one time at Pondicherry, the prompt was low back pain from outside. And whenever the location was identified, the patient showed the renal angle. And later on, it came out to be a case of pyelonephritis. The patient was taking SGLT2 inhibitor. So location for all the pain is very much important. And in our previous discussion, we have discussed the importance of past medical history, drug history, and family history. In short speaking, past medical history, drug history, and family history is truly a blessing for the long clinical consultation of PACES exam. If you ask them in details, in more than 80% of the cases, sometimes 100%, you'll get your diagnosis in the PACES exam within 2 minutes. But you have to know what question you have to ask for the past medical history, for the drug history, and for the family history. Unless you ask that specific question, the surrogate will not give you the answer because they are instructed to do so. So, after asking the morning jamming, Odipara, and liquor, the next thing is we have to rule out the red flag sign for every case of low back pain. What are the red flag signs? Red flag signs are any weakness, any change in sensation around the private part, then any change in sensation in the lower limb. All of these things, the first three things happens whenever there is cord compression. So we have to rule them out. And any loss of bowel and bladder control, which also happens in case of cord compression and cord achondrosis syndrome. Then the last and the most important red flag sign, that's number 5. It is, does the pain wake you up at night? If anytime any pain wakes the patient at night, it means this pain is either inflammatory back pain or this pain is due to any metastasis, due to cancer. Sorry. So never forget to ask this question. Better to memorize all the 5 questions that are the red flag signs. Then the next question is there any other joint pain? So based on the presence or absence of morning stiffness, excuse me. So based on the presence or absence of morning stiffness, we can divide the causes of low back pain into 2 types. One is inflammatory, another one is mechanical. The causes of inflammatory back pains are the seronegative spondyloarthritis. There are 4. They are ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and enteropathic arthritis. What will be the screening questions of them? For ankylosing spondylitis, there is no specific screening question. It is the low back pain, inflammatory nature. This is itself the screening question. Apart from this, for the AS, there is no other screening question. To rule out the psoriatic arthritis, we have to ask about skin rash. To rule out the reactive arthritis, we have to ask, do you have any discharge from your private parts? That is the urethritis. We have to ask, have you noticed any burning sensation while urination? So these 2 are the screening question for reactive arthritis. I'm again repeating, discharge from the private part and burning micturition. And whenever you are asking this question, you have to utter them aloud, so that you have to you have to prove to the examiner that you are ruling out reactive arthritis. To rule out the enteropathic arthritis, we have to ask the screening question of Crohn's disease and ulcerative colitis separately. The questions are, do you have any loose motion, any blood in the motion? Rather than asking any change in the bowel habit, the smarter approach will be asking them separately. Any loose motion for Crohn's disease, any blood in the motion for ulcerative colitis. It will prove to the examiner that you are a smart candidate. So this is for inflammatory back pain, and they are very much common. Each of the cases has come in the PACES exam. Then if the cause is mechanical, the causes are for the PACES exam either trauma or septic arthritis or osteoporosis, osteoarthritis, metastasis, multiple myeloma, prolapse of lumbar intervertebral disc, and psoas hematoma. To rule them out, truly speaking, you have to depend on the past medical history and OD-para. Let me give you an example. I will give you some example. But let me tell you that the cause of septic arthritis can be due to tuberculosis if you are giving exam in the Indian subcontinent. It can be due to discitis, and it can be due to brucellosis. So how to rule them out? You have to depend on the OD para and the past medical history, JAK history, and family history. Let me give you some example. Again, I'd like to have some interaction from the candidate. Right now, I'm going to give you some real cases example where I will show you how the PDF will help you. That's past medical history, JAK history, and family history will help you getting your diagnosis faster. So at one time, a case came at Pune. It was a case of low back pain to a young adult. His age was about 28 years old. In the past medical history, particularly in the travel history, he mentioned that he went to his father's cattle farm 1 month back. He visited his father's cattle farm 1 month back. And right now he's having low back pain. He's also having some fever, which comes and goes like undulating feature. So what can the difference of this? Yes, doctor, brucellosis. It was a dummy case actually. They just kept some medical student there with this history. Let me get back to another example. It was a case of 60-year-old male who is having low back pain. The prompt was low back pain. After entering, he was complaining that he was having this back pain for the last 5 days. In the past medical history, he is a diabetic patient, which is well controlled. But also in the past medical history, whenever this question was asked, whether there is any recent injury, he replied, recently while gardening, he had some injury at the leg. He got hurt at the leg. So based on this, what should the diagnosis? Yes, doctor, discitis. So unless you ask this history of recent injury, the surrogate is not going to give you the answer. Let me give you another example. It is also PACES case. Here, it was a 65-year-old male with low back pain. This low back pain was so severe that he had to wake up at night. In the past medical history, he has been diagnosed with prostate cancer for last 1 year. Let me complete it, doctor. In the JAK history, he's taking flutamide for prostate cancer. So based on this, what are your differential diagnoses? One is metastatic.
Drug-induced
Osteoporosis.
Yes, JAK-induced osteoporosis because flutamide is an anti-androgen.
Anti-androgen.
Yes, doctor. Again, past medical history, JAK history, and family history are the blessings. And also for 4 prongs, I have discussed in yesterday travel, we have to take the PET history. It's called PET exposure and travel history. It's a joint pain like low back pain. We have to take a travel history. You will get your diagnosis. But PDF is a blessing for PACES exam. Let me give you another example. It will be very much easy for you to diagnose. It is a case of 45-year-old old male. It was a male with low back pain. He is complaining of this back pain for the last 15 days. And in the past medical history, he has bronchial asthma. He had a flare-up 3 months back. Right after that, he had started steroid and he's continuing to taking that. Right now,
osteoporotic fracture.
Yes, osteoporosis. It can fracture or not fracture. In case of Okay, as you have mentioned the fracture, let me tell you some important thing. This is also a PACES case. It was something like that. In the differential diagnosis, you are noticing two differential diagnoses. One is prolapse of lumbar intervertebral disc. Actually, whenever the onset is sudden, while doing or lifting some heavy weight, at that point, you can mention this disc prolapse or the osteoporotic fracture. Because any type of osteoporotic fracture or disc prolapse will start suddenly. But all the other cases, they are actually not started suddenly. Dr. Focal weakness, actually in the PACES exam, they will not give you in a real weak patient. So in the examination, you will not find any focal weakness. They'll just keep some dummy patients there. But if the onset of pain is sudden, then this is due to any trauma or osteoporotic fracture or prolapse of lumbar intervertebral disc. Just keep this in mind. Sometimes you may be given a case like an old patient is complaining of low back pain, which started suddenly while gardening or lifting a heavy weight. So in that case, it will be prolapse of lumbar intervertebral disc or osteoporotic fracture. In this diet 1 at Dhaka Center, a case came with tummy pain. The case prompt was tummy pain, but after entering the station, the patient was complaining of low back pain along with tummy pain. He was also complaining of getting pale day by day. So can anyone guess what can be the diagnosis? Anyone is having
myeloma.
Wonderful diagnosis, doctor. What is the cause of tummy pain here? Can you explain?
Hypercalcemia.
Yes, doctor. So for myself, can you mention the symptoms of hypercalcemia that we can ask for the patient, starting from the head?
Low mood, polyuria, polydipsia,
Wonderful.
constipation.
Wonderful answer, doctor. You have given the right answer.
Confusion.
You can just add one thing. Gravel's
Mood
passing
change.
through. Yes, doctor.
A confusion, mood change. Yes.
Yeah, mood change means low mood. She has mentioned low mood.
Yes.
These cases come at Diet 1 and Dhaka Center. The prompt was tummy pain, but after entering, he was complaining of low back pain. We all know that the mnemonic is CRAP for any multiple myeloma. They are hypercalcemia, renal abnormality, which is usually found by investigation, not by any symptom. A means anemia, that is getting pale day by day, and B means bone pain. Okay, let me ask them. Yes, doctor. Yes, doctor. What is the question?
Could you tell us something about the profile of the patient with psoas hematoma?
Yes, doctor.
In which patient should we suspect that?
Yes, doctor. I'm just going to discuss this question, doctor. My next question is from that. It is also a PACES case. It was like a 40-year-old male with low back pain. In the past medical history, he had history of mitral valve replacement. In drug history, he is taking warfarin. So what do you think? What is the cause of back pain here? Any doctor?
Warfarin-induced hematoma.
Okay, you have given the right answer. Most of the doctors will think in this way, and you are right, partially. But what do you think? Like, this mitral valve replacement happened 10 years back, and he has been taking this medication for last 10 years. Why suddenly this time he has developed this psoas hematoma?
Anything he has been taking that is interacting with the warfarin?
Yes, doctor. Exactly.
Yes.
It can be over anticoagulation, but in the PACES exam, most of the time, it is due to any binge drinking or any drug interaction.
Any diet, anything like
we have to
fruit
ask
juice,
this.
some fruit juice interact with the activity of warfarin.
Yes, doctor. We can ask for the diet, but in the PACES exam up to now, they don't provide any diet changes. Most of the time, it is due to any drug interaction, like taking azithromycin or due to any binge drinking. So unless
warfarin by itself also can cause osteoporosis, no?
Yes, Dr.
Long-term
Warfarin can. Yes, it can also cause osteoporosis. Yes, doctor, it can cause. But they don't expect to that much level, truly speaking. In the
Heparin
PACES
not
exam.
warfarin, I think.
Yes, doctor.
Osteoporosis with heparin, not with warfarin.
I am not. I cannot remember the exact cause right now. Maybe it is happening. Not for
Heparin,
osteoporosis.
yes.
Yeah, it would happen. But heparin-induced osteoporosis case will not be given in the PACES exam, because in the first session we have discussed, we are being assessed as entering into the S3 level. Whenever you are going to enter into the exam, a British doctor will come and say you that we are not judging you as a consultant here. We are judging you as we are keeping the cases you face in day-to-day life. So, to my suggestion, I will suggest you not to go for heparin-induced osteoporosis for the PACES exam. Cases are not that much difficult, usually.
The diagnosis was like hematoma for increased warfarin activity.
Yes, due to binge drinking.
Due to binge drinking.
Why I have told this, it can be due to a drug interaction. I have mentioned this thing. Yes, doctor.
But sir, suppose on palpation we don't find any hematoma, then what we should then to give the same diagnosis?
In psoas hematoma, you will not find anything in palpation. It will be a dummy case. The only positive finding that you will get all the findings of mitral valve replacement. Even you will not get any findings of over anticoagulation, like any bruising. Because real psoas hematoma is not a stable case to be given in the PACES exam. They like to avoid this kind of real case, actually, doctor. Because whenever you are going to examine the patient, you will feel pain. You will check the movement of the lower back. You will feel pain.
Yes.
So
yes,
they will not give real cases in the PACES exam.
Okay. I have a question.
Sure, doctor.
So they sometimes say that, warfarin, like it will only unmask bleeding. It will not cause bleeding on its own. So is that correct? Is that the correct teaching?
Which one, doctor? Can you repeat your question again?
Warfarin, when we talk about over anticoagulation and we say that the patient is having bleeding from some side because the patient is on warfarin, will warfarin itself cause the bleeding, or will it only unmask the bleeding which is because of another cause?
In real life, there may be many causes of bleeding. Like the patient can have some underlying coagulopathy, but warfarin can unmask it. It is true. But I am requesting from myself that for passing the PACES exam, you don't have to think for such critical level, because cases will not be given in this critical manner like you are thinking. It is true that in real life, it is true. There can be some underlying coagulopathy like protein C deficiency, protein S deficiency on top of having warfarin. It is true for real life. But for passing the PACES exam to enter into the ST3 level, I will suggest this is not necessary to think. Did you get my point, doctor?
Thank you, sir.
You're most welcome. So what is the reason that I have mentioned this drug interaction? The reason is that unless you ask any recent dose change or any recent introduction or withdrawal of any medication from the drug history, the surrogate will be instructed not to give you the information. That is the reason you have to know what questions you have to ask for the drug history. And my suggestion will be to memorize all the questions in the given PDF provided to all the registered doctors. And over anticoagulation is usually not a PACES case. Most of the time, they will give some hidden drug interaction or binge alcohol, because binge alcohol drinking is very much common in perspective of UK. Is it clear to all the doctors? Any question? And for all the case of low back pain, never forget to examine the gait. If you don't get enough time to examine the gait, please offer it that I want to check the gait of this gentleman. In the PACES exam, try to avoid the term patient to show your professionalism. Try to use the term gentleman or gentlewoman, or young lady or young guy. And in the physical examination, whatever the cause of low back pain is, always examine the lower limb, ruling out cord compression. If you don't get enough time, at least check the plantar. By checking the plantar, you are showing the examiner that you are ruling out cord compression. which is a red flag sign we have already discussed. You will never get any real cord compression case in the PACES exam, but you are giving an impression to the examiner that I am ruling out cord compression by checking the plantar of the patient. Is that clear to all the doctors? Any question from this approach of low back pain?
Excuse me, doctor.
Yes, doctor.
Hello. Yes,
Yes.
regarding to the neurological examination, should I examine if even if the patient didn't have any red flag or complaint regarding
Yes,
weakness
doctor.
or numbness?
Yes, yes. Even the patient from the history complains of no weakness, no change in sensation around the private parts, that is saddle anesthesia, no change in lower limb, no loss of bowel or bladder. In spite of that, in the physical examination, at least check the plantar. You don't have to do all the physical examination, like checking the tone, power, reflex, coordination, sensation. It is not needed at all because you will not be able to cover it in time. But at least check the plantar. That's all. Then go to the real diagnosis examination.
Okay, thank you very much.
And in case of mechanical low back pain, check for point tenderness. Like whenever you are asking the patient, where are you feeling the pain? The patient will show you a point. And after taking permission that I'm going to press this area, if you feel any point, please, if you feel any pain, please let me know. It will be a dummy patient. So the patient will be instructed that whenever he is going to feel you that part, you will just make some noise that I'm feeling pain. But you have to look for that after taking permission, not without taking permission. Because any unnecessary pain happening to the patient will affect your mark in the welfare. So again, for the last time, anyone having any question or confusion from the approach of one of the Chivalester prompts today? That is low back pain. Should I proceed forward,
Which
doctors?
joint will the osteoarthritis affect? Like in low back pain, where is osteoarthritis most common?
Osteoarthritis is most common in the knee joint, but it can also affect the lumbar spine, causing low back pain.
Thank you.
Any other question, doctor?
Doctor, if I forgot to ask these critical questions you mentioned before, so I will not take marks or the case will be lost completely.
Sorry, doctor, I am not getting your point. Can you repeat your question again?
If I didn't ask or I forgot to ask a specific question to spot diagnose low back pain, for example, I forget to ask for any recent trauma or recent drug change. So I will lose the mark for the whole case, or because I will not get the proper diagnosis, but I will have multiple differential diagnoses. This is considered the failure?
Actually, doctor, regarding the mark distribution, it has been discussed in the first session. Whenever you are not getting this point, like you have missed the drug history, you have missed that there is a recent introduction of a medication called antibiotic, then you will lose mark in clinical communication skill. This is the mark sheet, you will lose mark here. Because you could not communicate clinically to the patient. You could not make out the right information from the patient that there is a recent drug introduction. And it is very much necessary to understand the mark sheet in details. We had a detailed, long discussion in our last session how the mark sheets are assessed. And in our discourse, I train personally every candidate to be a mentor. Like he has to know every ins and outs of the mark sheet, and he has to practice this by practicing mutually. Each candidate has to practice with one other, and they have to practice giving mark to each other. There's a whole new things for that. Did you get your answer, doctor?
Okay, thank you. Thank you very much.
Okay. So if there's no confusion, let's proceed to the next prompt. The next prompt is knee pain. It is the last triple star prompt of today. So how to approach to a case of knee pain? Like the previous prompt, first we have to ask whether there is any morning jamming or not. If there is any morning jamming, we have to determine the duration, whether it is more than 30 minutes or less than 30 minutes, because inflammatory pain will be more than 30 minutes. Then we have to analyze the symptom using the mnemonic OD-PARA, that is onset, duration, initial episode, progression, aggravating factor, relieving factor, and associated features. Then LICOR, that is location, intensity, quality, and radiation. Then the next question will be, is there any other joint pain? Okay, before approaching to the differential diagnosis, suppose the patient, whenever you are asking about the intensity and quality, the patient is complaining that the pain is very severe and the rating is 6 out of 10. So what should be your next approach to the patient to prove your professionalism?
Offer pain medication.
Yes, sir. Offer pain medication. And the examiner will just put his ear to you whether you are offering pain medication or not. If you don't offer pain medication, the examiner will cut your mark in this clinical communication skill.
Sir, I have one question. Like, just we have
Sure.
to say that, oh, I will offer pain medication, because actually, though, we cannot offer in that scenario, no?
Never, ever. You will not offer pain medication here. It is just acting. You just have to tell the examiner that, do you need any pain medication right now? He will tell you that, yes, that will be helpful. Then you have to mention that, okay, after our discussion today, I will arrange for you some pain medication. Is that okay with you?
Yes, sir, yes.
In reality, you don't have to keep some painkiller with you and offer this to you. If it happens, then from the 5 examiner, 5 candidate, he has to take 5 painkiller. This is not truth. So, right after LICOR and any other joint pain, based on the presence or absence of morning stiffness, we have to differentiate our differential diagnosis. If there is morning stiffness present, it will be either seronegative spondyloarthritis or rheumatoid arthritis. Regarding the seronegative spondyloarthritis, they are ankylosing spondylitis, psoriatic arthritis, enteropathic arthritis, or reactive arthritis. The screening question will be the same as previous. Whenever you are asking, is there any other joint pain? In the knee pain, if the patient tells you that the pain is at both the knee and also at both wrist joint, then you will get your diagnosis that this may be a case of rheumatoid arthritis. No other screening question is needed right after. You just have to touch all the points of rheumatoid arthritis and all other clinical features of rheumatoid arthritis. So this is for inflammatory knee pain. If the patient complains of no morning stiffness, then this is mechanical. The mnemonic is GHOST. Here G goes for gout and pseudo gout. H goes for hem arthrosis. For PACES exam, sorry, let me tell you later on. O goes for osteoarthritis. S goes for septic arthritis. And T goes for trauma. Let us come to one by one. For the gout, to rule it out, we have to remember another mnemonic. All of you know, I don't know whether all of you know, there's a parcel company named DHL. So you have to remember the mnemonic of DHL and psoriasis to remember the causes of gout. Here, D are 3D. They are diet, drug, and defect in kidney function. Diet means seafood and red meat. We just have to ask about it. That what about your diet? Do you take excessive seafood or excessive red meat? Then drugs, for the PACES exam, we just have to remember the thiazide diuretics. There are many other drugs like anti-metabolic drugs or anti-cancer drugs that can cause gout. But for the PACES exam, it is only the thiazide diuretics that we have to keep in mind. And defect in kidney function means CKD. CKD patient, we all know that, can have gout because the uric acid cannot get rid out of the body. So this goes for D3. Now come to H. There are 5 H. They are all the components of metabolic syndrome, like history of high blood pressure, high blood sugar, high blood cholesterol, and history of excessive alcohol, and history of smoking. If the components are there are components of metabolic syndrome, and metabolic syndrome can cause increased blood uric acid level, resulting in gout. The last L is all the cases of cancer, like lymphoproliferative disorder or myeloproliferative disorder. To rule them out, we have already discussed in our last session. Remember the triple L for any case of cancer. The triple L are loss of weight, loss of appetite, and lumps and bumps in the body. We just have to ask the patient, do you have any loss of weight, any loss of appetite? Have you noticed any lumps and bumps in the body? To rule out any case of cancer or lymphoproliferative and myeloproliferative disorder. This is for DHL, and to rule out psoriasis, we just have to ask, do you have any skin rash? This is for gout, and we have to screen for gout, asking for DHL and psoriasis. Let me know from the doctors whether there is any confusion or question from this gout. Clear to all? Okay. So after gout, the next case is pseudogout. Pseudogout is not that much common in the PACES exam. Up to now, I have not seen any case coming with pseudogout. Only one case came. Pardon for my mistake. For the PACES exam, the only one diagnosis we have to keep in mind for pseudogout is hemochromatosis. These cases come one time in the PACES exam. It was a case of secondary hemochromatosis. It was a diagnosed case of hemolytic anemia, that is congenital hemolytic anemia, and due to repeated blood transfusion, he has developed CLD. And that CLD, and this is a case of secondary hemochromatosis, the presenting complaint was knee pain. So for the PACES exam, the only one cause of pseudogout is the hemochromatosis. Then the next thing is hemarthrosis. For hemarthrosis, there will be past medical or the family history of bleeding problem. It usually happens in case of hemophilia. So we just have to ask, yes, doctor? Any question? Was there any question from any doctors? Okay. So to rule out hemarthrosis, we have to ask the family history. That any family history of bleeding issue. Typically, there will be positive family history because it is a case of hemophilia. To rule out the osteoarthritis, we just have to look at the age of the patient. There will be no screening question apart from this. If the patient is older, she is 65 or 70 years of age, and the pain is mechanical in nature, we can easily keep osteoarthritis as the differential diagnosis. But to rule it out, no screening question has to be asked. But if the patient is younger, at that case, we have to think twice before mentioning the osteoarthritis as a differential diagnosis. Then S goes for septic arthritis. This is a very much important cause. And there is an important twist for that. At one time, a case came, the prompt was knee pain. And it was a 65-year-old lady. She was complaining of knee pain. In the past medical history, she is a diagnosed case of osteoarthritis. And in her terms, she was mentioning that she has already been diagnosed with wearing and tearing of knee joint. But whenever this question was asked, any recent procedure? Right after that, she replied, yes, 5 days back, I had some injection to my knee joint. She cannot remember the name of the injection, but she's telling that she was having pain. That's why the doctor injected something to the needle inside her knee joint. And this answer will never be given unless you ask whether there is any recent procedure or not. That was a case of intra-articular steroid injection. And the diagnosis is septic arthritis. The last case is trauma. We just have to ask any history of injury or not. And that's all for ghost. If the case is mechanical knee pain, you can keep all the components of GOAT, but keeping the first that goes for the given case. And then tell the rest of them, but also mention what goes against the other differential diagnosis. I hope you got my point.
So regarding osteoarthritis, what two screening question should have checked?
Regarding osteoarthritis, there is no particular screening question. We just have to look at the age of the patient. If the patient is older, like more than 50 or 60 years of age, and the pain is mechanical in nature, we can easily keep osteoarthritis as one of the differential diagnoses. Did you get your point, doctor?
Yes.
And like any case of ankle pain, any case of pain, like low back pain and knee pain, examine the gait. It may be possible that the patient is not able to walk, but you have to offer that I want to check the gait of the patient. If the patient is not able to walk, the examiner will tell you that no need. So no need to examine the gait, but you have to offer it to gain the full mark in physical examination. And that's all for approach to knee pain. Let me know from the doctors whether anyone is having any question or confusion.
Hello, sir.
Yes, doctor. Please ask.
Yes, sir. Regarding gout, I have two questions. First, what is the most common cause of gout, and when prophylaxis is indicated in gout?
After the second episode of attack, prophylaxis is indicated.
Always we should wait for the second episode?
Usually, doctor. Right after the onset of first attack, it is not needed to start the prophylaxis. And also prophylaxis has to be started after the pain settles down. If you start the prophylaxis acutely, it can flare up the gout.
Yes, I know. No, yes, I agree with you. You are right. But I am asking you. Of course, prophylaxis would be indicated. Would be started in when acute stage settled down. But my question was that how many episodes we should see in a patient?
At least 2 episodes, doctor.
2 episodes.
At least 2 episodes.
Oh.
The case actually came with gout. It is like that.
2 episodes in once a year, or 2 episodes maybe for example, one is having today, and one another also having 5 years after.
Actually, doctor, regarding this answer, I have to check the guideline.
Within 1 year. Within 1 year. 2 episodes within 1 year.
I'm sorry, regarding this thing, I don't have the right answer right now. I have to check the guideline.
Doctor, there are 3 indications for prophylaxis. Hello?
Yeah. Please proceed, doctor.
Number 1 is 2 attacks within 1 year. Number 2, renal stone. Number 3, tophi.
Okay, yes. That is the answer, doctor.
You explain that point about intra-articular steroids. That patient received intra-articular steroids and was more prone to septic arthritis, or she received it because of septic arthritis?
No. She received intra-articular steroid for pain of the osteoarthritis. It is a recognized treatment for osteoarthritis. Whenever the pain is severe, the patient needs some relief for that. The orthopedic surgeon can try for some intra-articular steroid. But that intra-articular steroid injection is an antidote of bacteria, the skin gut, like the Staphylococcus aureus, causing septic arthritis. Yes, doctor?
There is no role. There is no role of steroids in septic arthritis. That's what you're saying.
Yes, never, doctor. No. On top of septic arthritis, if you give steroid, it will destroy the joint.
Doctor, what is about shoulder pain and hip pain? You will notice.
I will discuss this. Yeah. We're going to discuss this. They are actually not that much important. We are going to discuss this later on. But right now, let me know if any question left. Actually, the gout came in this way. The patient was having knee pain. And whenever it was asked that any other joint pain, the patient was showing at his big toe. So yes, sometimes I have pain at this big toe. So that was actually, can you guess it? What was the case there?
Gout.
Yes. That is why any other joint pain question is also important. So just proceed the flowchart, you'll get your diagnosis for me. Any other question from this knee pain?
No, doctor, thank you. It's very obvious.
Well, most welcome, doctor. If it is clear, now proceed. Now let's start the double step prompts. Double step prompts are actually less important to the triple step prompt, but also they can come. The double step prompt is ankle pain. First double step prompt. We have to analyze the ankle pain like the same way, OT para and LACOR and any other joint pain. And the approach is exactly the same as the knee pain. If there is any morning stiffness, it is seronegative spondyloarthritis or rheumatoid arthritis. If there is no morning stiffness, it is ghost. So basically the same approach for ankle pain with the knee pain. No difference at all. And also offer to check the gait. Clear to all, doctor? It is same as knee pain. No difference. Same differential diagnosis, same approach. Asking for morning stiffness, asking for OD para LACOR, and based on the presence and absence of morning stiffness, the differential diagnoses are different. Should I proceed forward, doctor? Any question from any doctors? Any question? Okay, Dr. Farah is only giving thumbs up. Okay, let's proceed to the next prompt.
Hello, excuse me, sir.
Yes, doctor.
Hello.
Yes.
What exactly is meant by ankle pain? Ankle pain mean ankle joint pain or heel pain?
Ankle joint pain.
Ankle joint pain. Okay.
Yeah.
And what we will call the pain where tendon inserted and the calcaneus bone.
Back of the heel.
Back.
Or heel pain or back of the heel pain. Heel pain. It is better to call heel pain.
Heel pain. But heel pain, when plantar fasciitis pain, that is what is called there. Also heel pain.
Also heel pain. That is why whenever anyone is complaining of heel pain, we have to localize the pain. Where do you feel the pain exactly? Tell the patient that show me the site. He will show you.
So tendon ankylosing and the plantar fasciitis, this is heel pain.
Yeah, plantar fasciitis is heel pain, and at the back of the heel, it is Achilles tendinitis. But whatever the cause of pain, if even the patient complains of ankle pain, tell him, show me the site of the pain, because it is very much important. For every kind of pain, localization of the pain is very much important. Tell the patient, show me the site. Where are you feeling the pain exactly? Did you get your answer, doctor? Hello? Hello, doctor. Did you get your answer? Okay. So one of the doctor asked, what does it mean by OD para and LACOR? Actually, it has been discussed in this course session multiple times. For you, sir, I'm repeating again, it is a mnemonic which was discussed in our first session. It is OD para means onset, duration, initial episode, progression, activating factor, relieving factor, and associated features. And LACOR means location, intensity, quality, and radiation. All of the question has been discussed, and what specific question to rule them out has been provided in the form of PDF to the registered candidate. So let's proceed to our next double step prompt. It is shoulder pain. So how to approach to a case of shoulder pain? Again, we have to tell the patient, show me the site of the pain. We have to identify whether it is unilateral or bilateral shoulder pain. Then the same way, OD para and first OD para, then LACOR, they're asking any other joint pain. For PACES exam, if it is unilateral shoulder pain, it is most likely adhesive capsulitis. Go to the past medical history, look for whether there is any history of diabetes or not. In the differential diagnosis of adhesive capsulitis, you can mention some local causes like supraspinous tendinitis or osteoarthritis. You just have to mention the differential diagnosis to gain the full mark in the DD. But the main diagnosis will be adhesive capsulitis for unilateral shoulder pain for the PACES exam, nothing else. Because this is the only medical cause that can affect the unilateral shoulder. Other causes are mostly orthopedic. So main will not be given for the PACES exam.
Can you please repeat what can be the cause for adhesive capsulitis?
Yeah, the cause of adhesive capsulitis is diabetes, doctor. Patient will surely have history of diabetes mellitus. It can be controlled or uncontrolled, whatever, but there will be history of diabetes. Examiner will ask you any other DD. So you just have to mention some localized orthopedic cause of joint pain. Yes, the frozen shoulder is also called adhesive capsulitis. The localized orthopedic cause of shoulder pain are supraspinous tendinitis or osteoarthritis. Basically rotator cuff tendinopathy. Then if the cause is bilateral shoulder pain, for the PACES exam, you have to keep in mind these three differential diagnoses. This can be polymyalgia rheumatica or polymyositis or fibromyalgia. In polymyalgia rheumatica, there will be stiffness at bilateral shoulder joint, but there will be no weakness. While in polymyositis, there will be weakness, but no stiffness. And the screening question of fibromyalgia will be unrefreshing sleep. We just have to ask, what about your sleep? Do you have any good sleep or not? Can anyone tell me, if any patient is having polymyalgia rheumatica, what other associated disease you should think for? Yes, doctor, Janssen-arteritis. Actually, in the PACES exam, Janssen-arteritis cases is given with the prompt of headache. And whenever you have to rule out polymyalgia rheumatica for all the case of Janssen-arteritis, which will be there. And that's all for bilateral joint pain.
In polymyositis, should have both stiffness and weakness, right?
No. In polymyositis and dermatomyositis, dermatomyositis was not mentioned here. Dermatomyositis will be also there. In polymyositis and dermatomyositis, there will be weakness, but no stiffness.
Okay.
In polymyalgia rheumatica, there will be stiffness, but no weakness.
No weakness. Okay.
Yes. And in fibromyalgia, there will be multiple tendon points, and there will be some psychological issue, like patient will be anxious, and there will be unrefreshing sleep. So we just have to ask, do you have any morning jamming? If there is morning jamming, then it is polymyalgia rheumatica. We have to ask, do you have any weakness combing your hair? If there is any weakness combing the hair, then this is either polymyositis or dermatomyositis. And what about to sleep? Do you have any good sleep at night? To rule out fibromyalgia. And that's all for shoulder pain for the PACES exam. Any question from this prompt, doctors? If it is clear, please give me clear, doctor. Other doctors? Yes. Everyone is becoming sleeping.
Doctor, I have a question, please.
Sure, doctor.
You told how we can screen for fibromyalgia.
Asking about the
question.
Sleep.
Refreshing sleep, yes.
Yeah.
What else?
What about
Anything
your
else?
sleep? No, nothing else is needed. In this case, the patient will mention that she is feeling pain at multiple body sites, not only on shoulder.
Yes. Okay.
The screening question about is the sleep. What about your sleep? Do you have any refreshed sleep? Or do you have any good sleep at night? She will give you the answer. And Dr. Sutish asked IBS. Actually, Dr. IBS is not given as the prompt of shoulder pain actually. For the PACES exam, it will be given either with the prompt of tummy pain or loose motion. Patient can have associated IBS with fibromyalgia. Yes, doctor. Patient can have associated IBS along with fibromyalgia. Okay, screening question for polymyalgia rheumatica. We have to ask about morning stiffness. We have to ask, do you have any morning jamming? Because in polymyalgia rheumatica, patient will have morning jamming. Got your answer, doctor? One of the doctor has asked what will be the examination steps. Actually, doctor, discussing the steps of examination is beyond this prompt session. And this is provided separately to the registered candidate. For the type 1 and type 2 slots, these physical examination sequences are given for each case separately. Like from this musculoskeletal session, I'm going to give 35 case PDF to the registered candidate, and along with a separate access to the physical examination sequences, investigation, and management for each of them. So it is provided separately. It is beyond discussion of this prompt session. So should I proceed forward, doctor? Okay, let's proceed to the next prompt. The double step prompts are already done. Now the less important triple step prompts: neck pain, diffuse body pain. Where is the hip pain? Yeah, it's a hip pain. So the hip pain is also the double step prompt, not the one step. So how to approach for hip pain? First Odipara, then LICOR. Then for the PACES exam, the most important cause of hip pain is the avascular necrosis of the hip joint. This avascular necrosis can be due to long-term steroid intake or can be excessive alcohol intake, and for the Middle East candidate, it can be due to sickle cell disease. And this is the most important one. If anytime any case of hip pain given in the PACES exam, one of the differential diagnoses will be avascular necrosis. It will be there for 100% sure. Another DD is osteomyelitis by salmonella. Let me give an example. This case actually came at one of the immediate center. I have forgotten the name. It was a 30-year-old female with hip pain. In the past medical history, she is a diagnosed case of sickle cell disease. And she had a recent episode of loose motion. Based on this, to the respected doctors, can you mention the differential diagnosis here?
Osteomyelitis by salmonella.
Wonderful answer. But first should be avascular necrosis.
Avascular, the dehydration.
Yeah, due to dehydration. You have given the right answer, doctor. The second answer will be osteomyelitis by salmonella, because this loose motion can be caused by salmonella. So salmonella-induced osteomyelitis will become the second DD here. This is for the Middle East centers, but for the Indian subcontinent, it will be given all the time with the background of taking immunosuppressive. Like we all know that renal transplant case is a very much common case for the abdomen station, short case. So they just put you or give you a renal transplant patient with the prompt of knee pain. He definitely is taking some immunosuppressive, like the steroid. So the definitive diagnosis will be avascular necrosis for this case. And there are very much little differential diagnosis, except for these two. I have not found any other DD for the hip pain for the PACES exam in the long clinical consultation. Any question from any doctors from this hip pain? If there is no question, please, can I beg a thumbs up reaction so that it becomes easier for me to clear for all? Okay, I've got many thumbs up. So let's proceed to the next prompt. Only two prompts are left, and they are very much less important prompt. One is neck pain. Neck pain has come only one time in the PACES exam, and the diagnosis was ankylosing spondylitis. So how to approach for neck pain? Same Odipara LICOR, any other joint pain, and asking for morning stiffness. If there is morning stiffness present, then it is either seronegative spondyloarthritis or rheumatoid arthritis. If no morning stiffness present, then this is mechanical neck pain. The causes of mechanical neck pain are very much easy. You all know it can be cervical spondylosis, cervical radiculopathy, or cervical myeloradiculopathy. Very much simple. It only came at one time with ankylosing spondylitis diagnosis. And that's all for neck pain. Let me know from the doctors if there's any question. Okay, can anyone ask me whether rheumatoid arthritis can come as low back pain? Is it possible, doctor?
No.
Yes, doctor, right answer. Rheumatoid arthritis does not cause low back pain. Please keep this thing in mind because sometimes some candidates make this mistake. Rheumatoid arthritis can affect the atlanto-occipital joint, resulting in neck pain, but never ever low back pain. Low back pain is caused by seronegative spondyloarthritis for the inflammatory back pain. Okay, let's proceed to the last prompt. It is actually, I should keep it in the double stir prompt because this is coming now, right now. It is not actually one stir. The prompt is diffuse body pain. Sometimes this prompt can be given with the prompt of muscle cramp. Just come, okay, let me write it. Muscle cramp. Muscle cramp or diffuse body pain, both can be given and the differential diagnosis will be the same. So after analyzing the symptom using the mnemonic OD-para and LICOR, we can jump into the differential diagnosis. Okay, diffuse body pain or multiple joint pain, both are the same. It can be given also with muscle cramp. Same prompt. The differential diagnosis are dermatomyositis or polymyositis, rhabdomyolysis. This rhabdomyolysis can be due to any drug-induced or exercise-induced. Drug means patient is taking some cocaine or taking some excessive NSAID. It can be due to viral myalgia or osteomalacia. This osteomalacia is due to vitamin D deficiency, or polymyalgia rheumatica or fibromyalgia. Apart from this, I have not seen any other DD for the prompt of diffuse body pain or multiple joint pain or muscle cramp. Let me discuss one by one. In dermatomyositis or polymyositis, the screening question will be any weakness combing the hair or getting up from the chair. For rhabdomyolysis, the favorite topic is statin-induced rhabdomyolysis. For the PACES exam, it is given frequently with the statin-induced rhabdomyolysis. At one time, it came with the prompt of muscle cramp. The patient was having history of taking statin, and right now, for some drug interaction, like this is a very much common thing. Like patient is taking statin for a long period of time, but why suddenly he is developing statin-induced myopathy? There will be some hidden issue. Unless you ask any recent introduction or withdrawal of any medicine, he will not give you the right answer. There will be some drug interaction like the erythromycin or something like that. Unless you ask this question, he will not give you. You can think like that patient is taking statin, so it is statin-induced rhabdomyolysis. It is not true. Patient is taking statin for quite a long period of time, but why he is developing rhabdomyolysis right now? There must be some hidden issue, and your job is to find out that hidden issue. Mostly it is drug-induced. Then it can be fibromyalgia. To rule it out, we just have to ask any recent sore throat. It can be due to osteomalacia, due to vitamin D deficiency. To rule it out, we have to ask about sun exposure. Do you have enough sun exposure? Just ask this to rule out osteomalacia, because there may not be any case of osteomalacia, but by asking this question, you are sending a signal to the examiner that you are ruling out osteomalacia as one of the TD. To rule out polymyalgia rheumatica, you have to ask about the question of morning stiffness. Yes, Dr. Shotish, we can ask about diet, but screening question will be sun exposure, because for the UK, they are actually solvent. Actually, dietary deficiency is very much unlikely, but for the lack of sun exposure is very much likely. That is why more than diet, sun exposure is very much important. But after getting the sun exposure positive history, lack of sun exposure, you can rule out the dietary history also. You have to do that, doctor. Then for the fibromyalgia, ask about night sleep. That is, do you have any, what about your sleep? And that's all for the prompt of diffuse body pain or multiple joint pain or muscle cramp. Any question from any doctors? This is going to be the last prompt of today's conversation. If there is no question, let me finish the prompt session by asking one question to all the doctors.
Can I ask you one question?
Sure, doctor.
So why are we equating multiple joint pains with diffuse body pain and muscle cramp? Because multiple joint pains, we'll look at whether they're symmetrical, asymmetrical, and large, small joints.
Patient may complain of multiple joint pain, and your diagnosis can be fibromyalgia. But apart from fibromyalgia, in the differential diagnosis, you have to rule them out, because sometimes patient can vaguely complain of multiple joint pain. But when you ask specifically where you are feeling the pain, she may show you that I'm feeling the pain all over my body. Maybe that is the reason. Did you get your answer, doctor? Your question is right, but this is a vague symptom. Like the actual diagnosis is fibromyalgia, but we have to rule out. Sometimes in your day-to-day life, if you will see, patient can come with some vague symptoms, like I'm having pain in my multiple joint. But whenever you are asking that where you are feeling pain, she will show you the whole body, that I'm feeling pain all over. So that is the approach actually. In my day-to-day practice, I have seen such like cases. Okay, so let me finish the session by asking an important question to all the doctors. Suppose you have got a case of rhabdomyolysis. In any case of rhabdomyolysis, it has a case came at one time. That was a case of rhabdomyolysis. Patient is taking statin, and recently he attended a marathon race. After attending the marathon race, he is having diffuse body pain. To combat the body pain, he is taking painkiller. There's NSAID. For any case of rhabdomyolysis, whatever the cause is, always rule out the renal affection. That is any high color urine, because
Globinuria.
Myoglobinuria. You have to rule out that myoglobinuria. And the patient was having that at the PACES exam. Patient was complaining of high color urine, and the urine amount was being decreased. So based on the information I have given to you, that patient was taking statin. Recently, he attended a marathon race, and we all know that in marathon you have to run a lot. That can cause some exercise-induced myoglobinuria or rhabdomyolysis. And to combat the pain, he is taking NSAID. So what safety netting you have to do to that patient? Any doctors?
Stop non-steroid.
Yes, doctor. Stop the NSAID. That will be the most important question in the clinical communication. And what happens in the PACES exam? Usually the examiner writes something beforehand in this section. They sometimes determine it beforehand. They write here, they will write here that stopping the NSAID or not. If you mention stop the NSAID, he will just make a tick mark there. So that will be the hidden issue. Any renal affection and the patient is taking taking NSAID or painkiller, tell him to stop the NSAID. Write them. Clear to all doctors? Any question? Let me finish the session by asking finally whether anyone is having any confusion from any of the prompts discussed today. Because in this course, what we do, or I do personally, we first discuss the approach to the prompt before starting for the practice session. After this prompt session, several practice cases will be given to each candidate to take preparation beforehand. Then at the next practice session, like the GIT practice session has not been held yet. For type 1, for batch 11, it will be on 10th May, and for batch 10, it will be 12 May. So for the previous GIT session, we'll do the practice session on 10 and 12. Also, this practice session will be announced later on for the musculoskeletal system. So may I ask if anyone is having any confusion for the last time? Dr. Mangala?
In rheumatoid arthritis, what screening should have done first? Joint deformity.
No, doctor. Just joint pain is itself a screening question. You have to notice whether this joint pain is symmetrical, because in rheumatoid arthritis, all the time the joint pain will be symmetrical. And ask the patient specifically which joint you feel the pain. Localization is very much important, because if the distal interphalangeal joint is affected, it happens mostly in psoriatic arthritis. But in case of metacarpophalangeal joint and proximal interphalangeal joint, it is rheumatoid arthritis. And you have to examine each joint separately. How to do the examination? It is described in detail in the physical examination video, which is provided to the registered candidate separately. And never forget to examine the complication for any type of pain. Yes, doctor?
Can I just ask you 2 quick points?
Yes, sure, doctor.
So I just wanted to ask you said that rheumatoid arthritis will usually not cause low backache. And there was one more comment which was made that osteoarthritis or osteoporosis will not be painful until and unless there is a fracture, isn't it?
Yes, you are right, doctor. Unless and until it is a fracture, it will usually not cause any pain. Yes, doctor, you are right, doctor.
Thank you.
But osteoarthritis of the lower back can cause pain. Any other question, doctor? Just let me ask to the doctors. Dr. Shabab, do you have any confusion, doctor? Dr. Shabab, any confusion from your side? Dr. Samia, any question or confusion?
No, sir. Thank you.
Okay. Dr. Mangala, do you have any question, doctor? Dr. Farah is clear, so I'm not asking. Dr. Raju, any question from your side?
No, clear.
Okay. Dr. Nahida, any question? Can I expect, doctor? Any question, Dr. Nahida?
No question here. Thank you.
Okay. Thank you very much. So that's all for today. So good night, doctors. Thank you for joining this session today. We hope you will take your preparation in a proper and coordinated way.